as a get going. Welcome to the last of the Ski Institute's Distinguished Lecture Series. And we're very pleased to have Simon Warfield here from Harvard University. We've known Simon for a number of years, and he is one of our official collaborators in our NIH for Integrated Biomedical Computing. So we get both a great seminar today and also collaboration with him. Simon is a professor of radiology at Harvard and Computational Radiology Laboratory at Children's Hospital. He's also the director of in radiology at Children's Hospital. So I'll let him discuss some of his new work and in diffusion tensor imaging and modification, tracking, etc., with applications in white matter deformations and autism. So please help join me in welcoming Simon Warfield.
Well, thank you very much for the opportunity to present here today. What I'd like to do is tell you about the work which we've been doing in assessing features of white matter and tuberous sclerosis complex. So first I'll tell you a little bit about the disorder known as tuberous sclerosis complex and give you a little review of how autism spectrum disorders and TD interact. And then I'll tell you some work we've been doing in imaging the white matter in our TSC patients. And then I hope to have some time to tell you some of the efforts which we're making to translate some of the technologies which we've developed into routine clinical practice. We'll talk about some work we've been doing in how to do imaging of complex white matter structure in a short amount of time, and also I hope a little bit about motion robust imaging. So first of all, about tuberous sclerosis complex. So tuberous complex is a disorder which is caused by changes in either the TSC1 or C2 gene. It affects multiple systems in the body. Some patients are diagnosed prenatally if a tumor is discovered growing in the heart, for example. It's an autosomal dominant disease. It occurs about 6,000 live births, and around about 60% cases are spontaneous mutations, about 40% are inherited from the parents. So sometimes we diagnose the parents after we diagnose their children. So prognosis varies in accordance with the severity of the symptoms. Many of the tuberous sclerosis complex also have epilepsy. More than 40% have a type of intellectual disability. And between 25 and 50% of the patients are diagnosed with autism spectrum disorder or with autism. Sometimes severe forms are very early in childhood, but this can be also a very form which we don't diagnose until adulthood. And what we don't know is that there are neurological deficits in patients with tuberous sclerosis. The underlying cause is unclear, and that's what we're trying to get a handle on. A lot is known about the nature of the pathology which results from these changes in the TSC1 and 2 genes. Here's an illustration of how tuberous sclerosis from an MRI scan, and in this slide of a piece of brain. So here we can see a nodule in the lining of the ventricles, and here we see a tuber on this slide. The cortical tubers show up as bright region flare scans, and these can change subependymal nodules. These nodules in the lining of the ventricles can change over time. So patients have an annual clinical MRI to see if these are changing or not. So what are these tubers? They're made up of very large cells which don't have an entirely normal phenotype. They're somewhere between glia and neurons. And these are cells in whom the normal regulation of cell growth has broken. They continue to grow and grow and grow. They're not cancers. Subependymal nodules can turn into subependymal giant cell astrocytomas, and then usually surgery is done to take them out. We know a lot also from animal models of tuberous sclerosis about changes which occur. So we have mouse models of TC1 and TC2 knockouts, a rat model, and also a fruit fly model. One of the interesting findings which has been observed in mice, the TC1 knockout, is loss of myelination, a loss of the normal process of myelination. So these images from mice at P7, P14, and P21. This is change over time. Control mouse, initially there's no myelination in the cortex, and over time, myelination grows. You see this filling in of the cortical structures. In TSC knockout, we don't have this normal progression of myelination. So in this model TSC, hypomyelination is a feature. TSC is involved in the mammalian target rapamycin pathway, and it's been proposed that mTOR inhibitors may be helpful in patients. So this has been studied in mouse models, and providing an mTOR inhibitor has been shown to improve myelination, can prevent seizures, and also improve learning in mice. So there's a ability that giving an mTOR inhibitor, such as rapamycin, may improve outcomes in these patients. There is a randomized controlled trial going to look at this question. So it's taking in groups of subjects 6 to 21 years old, doing a randomized assessment, 5 patients from 5 sites, and it's using neurocognitive testing to evaluate how these patients are doing. Secondary endpoints are measures of autism and seizures. So we will look to see how it turns out, how this trial goes. Previous trials of mTOR inhibitors have shown that sagas can be shrunk by giving a vaccine, for example. We do know that it's probably not a good idea to give everybody one of these mTOR inhibitors because they're known to be toxic. We would like to be able to give the right amount of mTOR inhibitor to the right patient if it turns out that it's an effective treatment. And this suggests a role for in understanding the relationship between change over time and dose, if it turns out that this is effective. Okay, so in tuberous sclerosis complex we have failure of the normal regulation of the cell size. We have aberrant neuronal connectivity, loss of myelination, and also loss of axonal guidance being seen in the mouse model. So how about the relationship between TSC and autism spectrum disorder? This is some data from a paper by Shefali Jest, looked at the diagnosis of patients with TSC as a function. So here we have repeated assessments of the same group of children. The red bar is diagnosed with autism. The kind of orange bar is a fraction of some kind of age, and blue is kind of a normal population. So one of the things which we know is that early diagnosis of autism or ASD is challenging and may not be reliable. But what we see here is a fairly consistent of around about 20 to 30% being diagnosed with autism and an ASD disorder. Around about 50% of the population. And it may well change with time. So what Shefali examined was cognitive impairment using the Mullen scales. And she found an association between cognitive impairment, autism 3, in these children. Children with autism are more globally cognitively impaired. Whether or not they were ultimately diagnosed with autism, a majority of the children with TS showed impairments in their place scores. So these findings suggest that there may be some common mechanism underlying both cognitive and social impairments in children with tuberous sclerosis complex. And perhaps the severity of that underlying impairment is what ultimately leads to the spectrum of outcomes, the identification of some kind of mild cognitive impairment, perhaps a diagnosis of ASD, and a diagnosis of autism at the most kind of severe end. So what could it be that is the common developmental deficit in all these children? One possibility that's been suggested is that early seizures can cause autism. There have been associations investigated which have looked at the relationship between early epileptic activity and the later diagnosis of autism. However, the literature in this area is still quite unclear, and while some papers have found associations, other papers have failed to find those same associations. So risk factors look to be very early onset of seizures. Earlier the seizures, the more likely a later diagnosis of autism, significant cognitive impairment. Now, it might be that the seizures are due to the tubers. We understand in TSC that tubers are the abnormal tissue from which seizures are generated. Is it that the tuber development causes seizures and that causes autism? If this case, perhaps there is some early critical maturation in which seizures, perhaps in the temporal, disrupt the normal maturation of the brain, and that causes a disrupted system which later leads to this social, behavioral, cognitive phenotype or autism. So an earlier paper by Bolton at the relationship between cortical tubers and later outcomes. Several other studies have tried to reproduce these findings and have found a similar relationship between the presence of tubers and later outcome. So one thing which we would like to understand is, if we are looking at tubers in the temporal lobes, are they necessary or sufficient for brain abnormalities? When other people have looked, they have not seen a relationship between tubers in particular regions and later outcome. Some have found that tubes cerebellum are very important. And so there's a significant literature which has not clarified the relationship between tubers and outcome and tubers and seizures. So we speculate that perhaps what is really underlying the changes in these brains is a misfiring of the axonal connections, and perhaps failure of myelination or failure of axonal guidance is the property which is of most importance in understanding the outcome in these children. So we talk about what we know about imaging findings in autism. The literature is pretty clear that there is evidence for an early exuberant brain growth at around age 2. And it appears this early exuberant brain growth is largely the growth of frontal lobe white matter in children with autism. People have also identified abnormal cortical gyrification, abnormal cortical thickness, aberrant proliferation of short connectivity, aberrant loss of long-range connectivity, and altered resting state functional network. So there's evidence for altered white matter maturation, loss of long-range activity, loss of functional correlations in that data. And a series of very nice papers has examined the potential role of disconnection syndrome in underlying diagnosis of autism. It's also been suggested that an early failure to integrate and synchronize language and vision leads to the failure of the appropriate systems to develop. So we see increasing evidence for autism as a failure of broad networks or the creation of appropriate systems. The diffusion MRI gives us a mechanism to go and look at those networks. Diffusion MRI will utilize diffusion sensitizing pulses to generate pulse, which depends on properties of water molecules throughout the brain. And an ICB in the human brain was first reported by Mosley in Radiology in 1990. And an ongoing debate in the literature has been how best to model that diffusion process. What is occurring in the white matter and how can we account for it? A common model first introduced by Vassar in 1994 is to represent diffusion as a diffusion technique. Other models have been developed and continue to be developed. And an open question is how best to go about inferring the underlying white matter microstructure. We started out being interested in the diffuser model, and that has a number of good properties. One is that you can fit a diffusion tensor from a rapidly acquired set of imaging data. This is an illustration of the kind of minimum set of images which you need to fit a diffusion tensor. And on a modern scan, it's possible to get relatively high spatial resolution acquisitions in 10 minutes or less. We make use of this kind of doubly refocused spin echo sequence that's proposed to avoid eddy currents. And we use parallel imaging to reduce geometric and intensity artifacts due to the long dwell time you get if you don't do that. Conventionally, it's been recommended by Jones and others, is 30 different diffusion directions in order to ensure that measurements of fractional anisotropy don't depend actually on the underlying fiber tract is pointing. So these kind of acquisitions are typically called high-resolution diffusion imaging or Hardy acquisition, and if they're done with one non-zero B value, we call that a single-shell Hardy acquisition. We know that optimal SNR, about 20% of the acquisition has no diffusion weighting, and it can be valuable to use least squares techniques to fit the diffusion tensor model. That's in particular important if there's in the scan. So how do we go about analyzing that data? Very often people have drawn regions of interest and then measured key parameters of the diffusion of those regions. People have also interactively delineated fiber tracts, made many distributions of parameters along those tracts, or summarized key parameters throughout those tracts. The key parameters are fractional anisotropy and the apparent diffusion coefficient or diffusivity, perhaps the volume of the tract, and axial or radial diffusivity. So here's an illustration of a representation of a diffusion tensor. We look at an eigenvector. This is the primary eigenvector. It has a size proportional to the eigenvalue here. And from this kind of shape, we infer two important properties: fractional anisotropy and this bulk mean diffusivity, also known as the mean diffusivity or the apparent diffusion coefficient. In children who are maturing, normally, then fractional anisotropy will increase with maturation, mean diffusivity will deep maturation. Fractional anisotropy increases with increases in axial density. It can be present in the absence of myelination. It increases with myelination. Myelination increases after the proliferation of oligodendrocytes, which stop the axons and start to form myelin. That proliferation of oligodendrocytes is associated with additional mean diffusivity, increasing numbers of cells, reduce the amount of extracellular water. It's also associated with the reduction of mean diffusivity. So these parameters reflect properties of the underlying microstructure, but are not entirely specific to one kind of change. So here's an illustration of a color-coded diffusion tensor image where the orientation of the fiber is causing this kind of classic representation of the color. It's possible to delineate different regions. This is part of the corpus callosum. This is the genu. This is the corpus callosum. This is the anterior lobe, the anterior limb of the internal capsule, on the left and on the right. This is the posterior limb. This is part of the motor system. These are projections to the frontal lobe associated with executive function. So in this work, this is from a paper with Michelle Krishnan, published in Pediatric Neurology in 2010. We examined regions of interest. We also examined fiber tracts. Visualize individual tensors in a voxel, this kind of picture. If we look at collections of such pictures, we can see fibers. Here it's easy to see the cingulum through this data. We have projections to the corpus callosum, part of the corticospinal tract. And so by putting together these different diffusion tensors, we can delineate fiber tracts. It's a visualization where we connect these regions together, and ultimately we pull out the bundles. Here's a visualization of the arcuate patient who has kind of a normal language. This is a normal pathway. So we do our tractography using a combination of techniques, some of which were inspired by work done here. Particularly, we use tensor deflection and primary eigenvector tracking. We use fragisotropy and angle criteria. The low-pass filter, the stopping criteria, trajectories as they're being constructed to help us go through regions of local dropouts. We do stochastically initialized tractography, start with many seed points throughout the whole brain, and we pull out the trajectories associated with those. We see those as being techniques for sampling from the space of all possible trajectories throughout the brain. What are the trajectories most compatible with the diffusion data that we see? We do subvoxally accurate stepping through the data using a log Euclidean intelligence scheme to represent the tensors across a voxel. So after generating all the possible trajectories, we can identify particular fiber tracts based on regions that they pass through or regions that they pass through. So we can use selection and exclusion regions of interest to select particular tracts. Recently, we've worked on trying to automate that process, represented by Ralph Suarez at ISBE earlier this year. So here's an illustration of how we might select regions of interest to represent particular fiber tracts that we're interested in. This is a visualization of an image, and here we've delineated part of the lateral geniculate nucleus and part of the occipital lobe white matter. And we will require tracts to pass through both of these in order to identify the optic radiation. And here's a view from a sagittal image. This is an example of delineating part of the corpus callosum, where it stands out and is very easy to see. We would like to have to manually identify those regions of interest in every subject. So we've looked at adequately identifying those regions of interest for us. We developed a process whereby we label a group of template subjects, and throughout the white matter, we identify the important anatomical constraints. We use non-rigid registration to project each of these templates onto the target, and then we form a label fusion, identify the regions in the individual, and generate the tracts from that. We select the tracts from that. Here's a visualization. In green is the manually generated tracts, and in white is the automatically generated tracts from those same selection regions. So see that there's a close match between what we generate interactively and what we generate locally. So Michelle Christian looked at TC patients in 6 controls. We did diffusion imaging. She drew regions of interest, and we looked at parameters in those regions. We also looked at the geniculocalcarine tract. We found diffusion abnormalities between controls and the TSC patients in that geniculocalcarine tract, and primarily, and in the regions of interest, mainly in the spleening of the corpus callosum. So here's a visualization of how that data is different in a 17-year-old girl with tuberous sclerosis complex, and this is a 17-year-old girl who doesn't have TSC. This is a healthy control subject. And just visually, it looks like there's a kind of a striking difference in the amount of trajectories which we generate. Here's another illustration. This is a 5-year-old with tuberous sclerosis complex. You can see traumatic asymmetry of pathways generated through the geniculocalcarine tract. And here's the pattern we expect to see in a healthy 5-year-old. So it's kind of a striking difference just visually. When we look statistically, of course, we also found these differences. So we see variations of the underlying white matter microstructure in these regions that are consistent with organized and structurally compromised axons with poor myelination. In Michelle Christian's work, what we found was that the visual and social cognition systems appear to be involved. And we thought perhaps these may correlate with the behavioral phenotype. So we wanted to look to see if there was a relationship between behavioral phenotype, as indicated by a diagnosis of ASD, and a variety of changes in the underlying white matter. So we recruited of TSC patients. We looked at 40 subjects, 12 of them with diagnosis of ASD, and 29 age-matched controls. They all under MRI, including diffusion imaging. We decided to sample the white matter brains by focusing on the corpus callosum. So we selected a region of interest in the corpus callosum, and we generated fiber tracks consistent with the projections through the corpus callosum. We made a measure of fiber tract density of the callosum, and here, kind of close by the midline plane, you see this primary tract density in the corpus callosum, and further out away from the midline, you see the different changes in the density of the projections of the corpus callosum. And then we construct tract density weighted estimates of the fractional anisotropy and mean diffusivity, so axial diffusivity and radial diffusivity in all those regions. So we used tractography of the corpus callosum to define a three-dimensional volume of interest. We made fiber density weighted estimates of these parameters. Fiber density weighting means we treat each trajectory we generate equally rather than each vol above some threshold equally. And it accounts for the differences in tract frequency throughout the volume of the brain. Visualization of the corpus callosum in a control subject, a TSC patient without a diagnosis of autism, and a TSC patient with autism. And what you can see is this is a little bit less proliferation, but this is strikingly different. So in order to quantitatively assess parameters in these regions, we took the DTIs as response variables in a regression model, and we examined, we took into account age, gender, group status. The group first being controls versus TSC, and then controls versus T plus ASD and TSC without ASD. So visualization of the average mean diffusivity in the region defined by the corpus callosum, function of age, this is the average mean diffusivity in that region, and we have three groups. We have a control group down here, and so as of time you see this normal decrease in the loss of mean diffusivity. So the brain's out having lots of extracellular water, and as cells grow, especially over the first periods in life, you have a proliferation of cells, and then a maturation of the white mean diffusivity should change, should decrease. This is TSC patients without ASD, and this is TSC patients with ASD. So we can see that there's a difference between, in the trajectories, the development of the white matter here. With the controls, this defining what is TSC patients without ASD being closest to that, and TSC patients with ASD being most. It's interesting to kind of look backwards and see when does these first become, how early might we be able to see differences here. Here's a similar image looking at the radial diffusivity. You see a similar pattern to the diffusivity. And axial diffusivity, again a very similar pattern. And here's the visualization of the maturation and change of fractional anisotropy over time. So fractional anisotropy we expect to increase time. And here we see two lines almost overlapping. These are the lines of the controls of the TSC patients without ASD. And this is the fractional anisotropy of TSC plus ASD patients. So we see near normal pattern of anisotropy changes in the TSC patients who don't have a diagnosis of autism, a much larger difference in fractional anisotropy in the TSC patients who do have a diagnosis. Here's just a table summarizing different group comparisons. This is the 4 different measures. Mainly look at the mean diffusivity and fractional anisotropy. Comparing controls versus TSC, all cases, and controls versus TSC without ASD, controls versus TSC with ASD, and then TSC minus ASD versus TSC plus ASD. So what we see is a significant difference between fractional anisotropy and TSC plus ASD and compared minus ASD. We see a number of statistically significant changes in the diffusion parameters which define the differences between controls and TSC patients. So summarizing, we examined D measures of projections of the corpus callosum, and we found that the TSC patients have different measures compared to controls, and the TSC patients without ASD are also different. All four measures show differences between the two control subjects. The average fractional anisotropy was statistically different between the TSC subjects with ASD and those without. It was AFA was reduced in TSC subjects with ASD compared to those without ASD and to the controls. So again, these altered DTI parameters tell us something about microstructural white matter abnormalities in the TSC patients. They don't have high sensitivity to particular changes, but they are consistent with changes in myelination, axonal E, and with changes in the extracellular environment, how much water is present. Reduced fractional anisotropy of TSC subjects with ASD is consistent with the decreased long-range connectivity in ASD. It may well be that imaging studies in the future may find that early differences in these parameters allow us to predict ahead of time who will be at risk of diagnosis of ASD. So now I'd like to tell you about some work which we're doing to increase our ability to probe the underlying white matter changes, work which we're doing to allow us to do a better job of compensating for motion in a number of these kinds of imaging studies. So diffusion tensor imaging is a very nice way of allowing to characterize the large white matter fiber bundles in the brain. It gives us non-invasive measures of white matter properties. And although a nice property of the diffusion tensor is that it gives us access to these parameters, fractional radial diffusivity, which allow us to say something about the environment that we see. We would like to not give up on those measures. They're good in regions in which there is a white matter fascicle is highly oriented, in which there's essentially just one structure. However, in regions with more complicated underlying white connectivity, the spatial resolution of MRI, a single diffusion tensor model loses its ability to tell us about the microstructure of protein. And the question has been how to go beyond a single diffusion tensor model to appropriately take that into account. So other techniques have been proposed for overcoming this limitation of diffusion tensor imaging. I want to kind of briefly review some of these techniques and kind of lay out the space of alternatives to a diffusion tensor image. Techniques want to characterize diffusion in a more sophisticated manner, use some kind of space sampling. We can regard every diffusion-weighted image as a sample in Q. And one strategy for completely characterizing diffusion properties is to sample Q space very densely. This is a visualization of Cartesian Q space sampling from the work of Hardman et al. Each image, however, takes some time to get, and sampling is an expensive strategy to use. The alternative to that, which has been suggested, is to sample in Q space. And this is what we do when we do a single Hardy acquisition. Multiple such spheres, this is a sphere in Q space, multiple spheres can be examined, in which case you have a multi-shell Hardy acquisition. And so once you've got that acquisition, you can go more sophisticated representations of the underlying diffusion signal. And analysis have been proposed. Diffusion spectrum imaging suggests that no parametric appropriate. and that by doing dense sampling in Q space, you can represent everything you know about the diffusion signal. However, unless you sample everywhere in Q space, this measure is subject to quantization artifacts. Quantization artifacts can lead to difficulties in interpreting those changes in the diffusion signal. Q-ball imaging and exact Q-ball imaging undersample Q space more than the assigned strategy, and in return require, again, some additional assumptions about the nature of the diffusion signal and lead to images in which a characterization of the diffusion-weighted signal can be made. There are also parametric models such as GDDI or dot imaging. These have in the characteristic that their goal is to describe the general shape of the diffusion profile of a voxel. But their goal is not to consider properties of multiple fiber bundles. In Q-ball imaging, it's possible to generate, for example, generalized fractional anisotropy, but the generalized fractional anisotropy is a property of the voxel, not a property of each fiber in the voxel. So you do not get to characterize the proportions of each fiber bundle, and you don't get to get those parameters which characterize those fiber bundles. Those are two things we would like to be able to do. One way to do that is to directly model multiple fibers. We can consider in each voxel a mixture of independent fibers. And one of the early models to examine this is the work of Behrens and others, and they use a kind of a ball and stick model. Each fiber bundle is represented essentially by an orientation, and the ball refers to a total amount of diffusivity at a voxel. So we think a good way to represent multiple fibers is to use a multiple tensor representation. The advantage is that we know that an individual fiber bundle is well represented by a single tensor, and with multiple fiber bundles ought to be well represented by a set of tensors. Because you have a tensor parameter for every fiber bundle, you get to characterize each fiber bundle in the same way we have done historically. So that's a desirable and good thing. However, multiple tensor models for multiple fibers have regarded as being numerically challenging and unstable to fit. There's a number of papers in the literature which suggest they're hard to numerically fit. So, in a paper at ISBE last year, we showed that one of the reasons why these numerical fits are difficult is that in some cases the imaging data is being fit in a case where only non-zero B value was acquired. What we showed in this paper is that if you want to represent a full multiple tensor model and the fraction of octave of each tensor in that voxel, then you must have multiple non-zero B values. If you only have a single non-zero B value, then there's a collinearity, a numerical algebra problem in telling the difference between the primary eigenvalues of your diffusion tensors and the fraction of octave. Yeah?
So it seems like there might be multiple ways in which you could formulate the combinations, the way in which these different bundles are made. I can imagine several different ways. Does this result depend on that? Is this really, in some sense, describe a shortcoming of a particular way of formulating
a multiple tensor model? I don't believe so. The real assumption in the multiple tensor model is that there's no exchange or slow exchange between the protons associated with one fiber bundle and the protons associated with the other fiber bundle. And if there's no crosstalk between them, then the multiple tensor model is a perfectly good thing. And the details of how multiple tensors are represented is not important to this collinearity. And if you go carefully through some of the earlier work, they have often solved this problem by assuming the values of certain parameters or assuming that the fractions are known ahead of time.
Assuming the anisotropy of each tensor.
So assuming that they're the same, for example, and that turns out to have significant negative consequences on the quality of the tensor fit. But if you have two non-zero B values, then there's no collinearity, and you can solve exactly for these parameters. We presented that at ISMR and at ISB last year. So what I want to present here, yes, sure.
So how do you do the market tensor estimation? How do you do the diffusion process?
I'm going to tell you all about how to do it.
How do you decide like each box of how many tensor you want to fit?
I can tell you how to do it. And I can tell you how you should be doing your acquisition so that it doesn't take you too long. And I'm going to do it in about 10 minutes. So, the two things I want to present. One is an acquisition strategy to give you the data that you need to fit a multi-tensor model. And the second thing is a strategy for fitting a multi-tensor model. The acquisition strategies is a cube and a sphere in Q space. Cube and sphere, we call this a cusp acquisition. And it's going to allow you to fit your multi-fiber model. Now, your multi-fiber model is we're going to use a tensor model. If you like, you can add certain constraints. You can assume axially symmetric tensors. Other constraints might adversely impact the quality of your tensor estimates. So why a cube and sphere acquisition? So I can tell you that you need multiple b-values to do full multi-fiber model estimation. How can we get those multiple b-values without having to pay a penalty? First thing to understand is that the maximum b-value, the echo time of your acquisition, and the gradient strength are all. This is your b-value, this is your gradient strength, this is how long you spend with your sensitizing gradient going. These all depend on each other. If you change the kind of nominal b-value here, you are in effect altering your echo time. So if you take a single shell Hardy acquisition, you have to have a b-value of 1000, that implies a certain TE. If you take that same single shell and say I'd like to have a b-value of 3000, that implies a different TE. And TEs mean different geometric distortion, that means different signal-to-noise ratio, and different density distortion. Your data doesn't line up properly. So one strategy to do multiple shell Hardy action is to pick b equals 3000 and do a b equals 3000 acquisition with a certain TE that you have to have, and a b equals 1000 acquisition with the same bad TE that you had to have to get b out at 3000. And we're going to show you how to avoid that. How do we get multiple b values? Okay, so I just went through this property. Single shell Hardy acquisitions don't line up, different TEs. SNR at 3T is a TE, not just a function of the b value, but a function of TE. You'd like to have the highest SNR possible, so you want to have the lowest TE possible. In a multiple shell Hardy addition, the TE that you get is the TE for the highest b value. That's undesirable. What we like is a TE for the lowest non-zero b value. So how can we avoid having to pay that penalty? And what we realized is that you don't really need to do a full shell. So what we're going to do is combine one Hardy shell and gradients on the enclosing cube. And we're going to show how this can be used for multiple assessment. So imagine this Hardy acquisition. This is the conventional single shell acquisition. On this shell, the gradients of the scanner are being driven with a way that has unit norm magnitude. So the b value that you get is proportional to the b value of your shell and the norm squared of your gradient. So here this is 1 for this shell. We can have higher norm gradients. This hexahedral gradient has a norm squared of 2. And what that means is the b value that we get is the nominal b value times 2. So we get a b value. But this doesn't change our TE. Our TE is still determined by our single shell acquisition. Similarly, where's the gradient 2 at? It's where the x gradient and the y gradient run to the y gradient and the z gradient run twice. They're on the edges of this cube, on the faces of the cube. You can also turn on all 3 gradients simultaneously. So that's here, 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 here. The norm of this norm squared is 3. You get 3 nominal b value. And you don't have to increase the TE. This cube encompasses all the region with the same kind of minimum TE. And you can put your gradients anywhere you want in So this gives you a mechanism for getting all non-zero B values. It gives us high B values, which are valuable, without increasing the TE, doesn't change the imaging time, doesn't give you increased distortion. Given that kind of acquisition with multiple non-zero B values, you can then fit multiple fiber model. So this is how we would represent our conventional diffuser. We have a baseline image and an image which depends on the diffusion tensor. And note here that we write BK because we might have a B value in our gradients. Here's an example of for two, say, diffusion tensors. Two anisotropic components related to fibers. We can also inject a component related to free water diffusion, unrelated to the diffusions. We explicitly model how much of each is present in the voxel, and we have three different. This is a purely isotropic diffusion. This is a single tensor, and not a single tensor. So essentially, we want to be able to identify the parameters of that model without spending a lot of time, a lot of compute time, and without with being sure that we won't get, say, negative eigenvalues. The way we chose to ensure that properly is to use a log Euclidean representation. And this has the advantage of ensuring that tensors with null or negative eigenvalues, which are not tensors, are at infinite distance solution. So we formulated as a variational framework, term dependent and a regularization term, and we just minimize this. So we have Ray's criteria, the spatial homogeneity criteria. We can induce here a capability to do an isotropic regularization, which can help us to compensate for motion. Children will often move during some of the scans. This gives us a way to remove outliers. So now I'm going to present some synthetic experiments evaluating the model, and then some visualizations for some clinical data. So here's a numerical simulation. This is a kind of a 10 by 10 grid of numerically generated diffusion tensors. You can see the pattern of crossing changes, so there's multiple different angles involved. And we simulate the diffusion-weighted signal, we corrupt it with the Rissian noise. This is the ground truth. If we simulate a single shell Hardy acquisition, and we solve for tensors per voxel, we get something which does not look very much like ground truth. If we do the same thing with a cube and sphere acquisition, exact number of images, but distributed 16 on a shell, 1 on the hexahedral elements and 2 on the tetrahedral elements, then we get this fit much closer to the simulated data than the single shell Hardy acquisition. So one question is, what direction we image at? What's the best way to do that? And the way we've started to think about this is to think, how much imaging time do we have? How little imaging can we get away with? If a certain amount of imaging time we want to use, what is the right balance between the Hardy acquisition, non-Hardy diffusion directions? So in this simulation, we compared the distance between ground truth tensors and the estimated tensors for a fixed number of single shell acquisitions. And then this is a number of tetrahedral and hexahedral images being applied. So here we increase the imaging that we do, so we increase the amount of imaging time, and the blue color represents most error. So we want to get to a spot which is blue. And what you can see is that depending on how long image, there's a balance to be learned between how many tetrahedral gradients and how many hexahedral gradients that you have. So we have a little linear equation which says if you have a certain amount of imaging time, you're going to get a sum of gradients. How should you divide them up? This is one way to do it. And in practice, we have had good experience even with 35 images. That takes about 5 minutes of imaging time. So here's another visualization where we compare various crossing angles we looked to compare with the ball and stick model of FSL. We used the average minimum angle proposed by Tuck, and here are four things being compared: a cusp acquisition and a Hardy acquisition, the cell solution and the MFM solution. Remember here we're just comparing angles, we're not taking out the fact that the MFM model gives us the full tense, FSL model just gives us a ball and stick. What's the best? The lowest is the green line, it's the cusp acquisition over almost all of these crossing angles. Hardy FSL, initially a little bit higher error, down again. Here is the Hardy MFM, which has some regularization built into it. And this is the FSL result on the cusp position. And it's a little surprising that those aren't so good. I think what's happening is that some of the additional noise in the tetrahedral and hexahedral acquisitions is perturbing the model that the FSL solution is expecting. So here's another evaluation. This time we look at the distance between the tensors, and this is the distance between estimates of the fraction of occupancy. This is the amount of noise we're adding. So lower is better, and be as close as possible to the true tensors. The cusp MFM acquisition is very good. Here's a comparison between a 35 direction Hardy acquisition, 156 direction Hardy acquisition. What you see is that they tell you almost exactly the thing, because the problem is not really one of total SNR, it's one of being able to resolve tensors in the voxel. So if you have a lot of imaging time to spend, don't spend it all imaging at the same p-value, change the p-values. And the same is true in the estimate of the fraction of occupancy of the tensors. Why is it important to be able to estimate the fraction of occupancy of the tensors and to be able to estimate the FAs and the MDs also? Well, here's exactly the reason. Imagine if you have two fiber tracks perfectly uniform crossing through some region. Perhaps you want to examine the possibility that you have a normal process in controls and you have a disease process in some particular neurological order. What you would like to be able to do is independently evaluate the fractional length of each fiber bundle. If you solve for a multiple fiber model of the acquisition, this is an illustration of doing that, what is that the quality of your estimates of your FA are not very good. And realize that here by using both color and displacement in the Z direction to indicate deviation from the correct answer. Here's the same visualization for the cusp MFM solution. Again, you have a straight line here and a varying line, straight line here. The green regions where the FA is not quite right. So it's much larger here, smaller here. Here's another way to look at that same data. This is just along a particular tract. This is the region of, in the Hardy model, in the model fit from the Hardy data, we see this big change in one of the tensors. Whereas in, we see this big change here. Whereas in this model, we have the representation here is much better. So the Hardy model changed, the cusp model doesn't change. All right. So here's a visualization from the data acquired on our 3T Children's Hospital. What we had here was a Hardy acquisition and a cusp acquisition. The thing that we see in this data is better tensor uniformity in certain regions, 1, 2, and better alignment of the two tensors in regions where a single fiber is present. Your question of how should I know when I should have one tensor and when should I have two, that kind of a model testing problem. And what we have found is that we compare the model that we get to the data, and that allows us to work out in what regions we should use a single tensor solution and what regions we should be picking a multiple tensor solution. Here's a comparison on the same data with the FSL kind of ball and stick fits. What we found was that these appeared to be much noisier the estimates which we got from the same data. So probably this input is not what the FSL algorithm is designed for. Here's a visualization of some tractography from a Hardy 45 position and a Cusp 45 multiple fiber model. So the same amount of imaging time. These are more like what we expect the true tracks to be. It's a visualization of the arcuate fasciculus. We see more of the projections of the arcuate in this model. So we think that the cusp model allows us to get a better handle on the tracks which are present. So the components of the model that we have are a novel fitting procedure that allows us to ensure that we can fit positive symmetric, positive definite tensors, and a variational formulation which allows us to account for artifacts and to regularize, and an acquisition scheme which allows us to get the non-zero B values that we need whilst not paying a penalty for increased distortion, not paying that increased distortion. There's more work to be done. One of the things to understand, most of our evaluations which I've presented today have only 2 non-zero B values. Have used single shell hard to more non-zero B values, and there's a wide parameter space on non-zero B values to evaluate. We think that we can generate more B values, and that will allow good characterization of perhaps even tensors per voxel. Model selection, we've worked on the model selection problem, and we think we can do a good job getting the right number of tensors every voxel. And we would still like to go and do direct comparison with other techniques for representing more complex white matter bundles present in particular voxels. So how am I doing for time?
It's about 3 o'clock, so you get a few more minutes.
A few more minutes? So maybe I will just go very quickly through some of the work which we've been doing in motion compensated, if that's okay, or I can just take questions. So motion compensated MRI is particularly interesting and important in fetal MRI. Some of our tuberous sclerosis patients are identified prenatally when they're discovered in the heart. We would like to be able to do high resolution imaging to characterize these developing brains. So what does conventional fetal imaging look like? So this is a visualization of an axial fly through of the fetal brain. And in particular slices, you can see the brain, but you can also see how much motion there is between the snapshots. This is a coronal acquisition, and here's a little acquisition. So you can see the hands moving around, you can see the head moving backwards and forwards. And as a result, if you try to stitch these images together, while every 2D image looks nice, the sagittal and coronal acquisitions don't look nice because of this motion of slices. So we can't get fetus to hold still. We can't do very much about the nature of the individual fast single-shot acquisitions because we need that SNR. But we need high-quality 3D fetal brain MRI. So one approach to trying to get that would be to just take lots of images and average them together. Fortunately, without compensating for that motion in some way, it's insufficient. You can't get good images. So averaging doesn't let us do what we do. So we need to add motion. So how can we go about doing motion correction? What we were inspired to do is to do slice registration, and we were inspired to do this by the work of Colin Studholme and Joe Hanel, who have demonstrated that it's possible to make slices and align them to volumes, and to use a scattered data interpolation approach estimating volumetric images. Our approach is different from the scattered data interpolation approach by incorporating an exact model for how the images are acquired. So we imagine we have some object which undergoing some motion, it's undergoing some subsampling, it has a certain, so there's motion, there's a slice selection, there's blurring, there's downsampling or decimation to get the final image that we see. So this we'd like to have this on a discrete lattice, and this is what we get. It turned out to be important to model this profile here. So we find the problem of finding the high resolution image is an inverse problem, where we make a measurements of single shot fast spin echo MRI, and we solve this estimation to get this high resolution volume. And we do that through this super resolution reconstruction process. We carry out iterations of slice to volume registration, scattered data interpolation, and then a maximum likelihood super resolution reconstruction process. We start off with slices. We assume that they're all aligned, even though we know they're not. We estimate a volume. We estimate a high resolution volume. That gives us a good volume. We compare whether or not we've made any change in the previous iteration. If not, we rerun the iteration. We re-estimate the volume. And so that allows us to build a high resolution volume. Here's an example of what that looks like. This is kind of the input. We acquire multiple images which look like this. We generate this kind of, and so this is a nice 3D representation. This is not suitable for 3D analysis. Here's another illustration of the 36-week fetus. Again, it's hard to do analysis of this data, so high resolution reconstruction we're able to get. We can even compensate for dropouts, poor SNR in individual slice. This allows us to reconstruct a nice high resolution volume. Although all the inputs are 2 millimeters, the reconstructed lattice is at 0.8 millimeters isotropic. From that kind of data, we can then interrogate the 3D volume, and we can do segmentations, visualizations. This is a kind of a normal 32-week, roughly 32 weeks. This is from a fetus with craniosynostosis, 37 weeks. The pattern of the ventricular system here is highly abnormal. We're not limited to doing this in the brain. Here's an illustration showing the brain and the body, the lungs. You see the esophagus here, the spinal cord, balls. So we can see many structures in the brain and also in the body. Now we were started down this path by our desire to do good quality imaging of the fetus, but the fetus is kind of inaccessible. Other children also don't hold still, but they are accessible, and we can use a hardware-based sensor to track their motion. So recently, we've started using like this, which can provide us with real-time tracking information. So we attach the sensor to the head. As the head moves, we measure the motion, and then we can use these motion parameters to help us with our slice to volume registration problem, and then we get a high-resolution volume. So here's an illustration of that process. This is the output, building a high-resolution image. This is what the reference volume looks like. And in fact, our reconstruction from multiple such volumes is actually nicer than the reference volume. Finally, even in the absence of motion, it is still interesting to try the high-resolution reconstruction of this data. Here's an example from imaging of a TSC patient. You can see here a nodule in the lining of the ventricles, and here is coronal data. There's a cortical tuber. So these patients whom we image clinically, this is an axial acquisition, and you can see coronal and sagittal views that the spatial resolution of the data is about 0.5 by 0.5 millimeters. And here we have a coronal acquisition, and on the plane of the acquisition, there are some artifacts from the slice thickness partial volume artifact. A pure scattered data interpolation is a little bit blurry, but a nice reconstruction allows us to estimate from just those two acquisitions a high resolution 3D T2 weighted volume, which is much sharper than the individual volume and has reduced partial volume artifacts. This is a high-resolution image provided about 1 by 1 by 1 millimeter. You can compare the anatomy between this reconstruct and this high-resolution data. So we think that these kind of multiple acquisition, super resolution reconstruction techniques are going to allow us to increase spatial resolution for characterizing 3D brain structure and for compensating for motion, both in the fetus, where we don't have a lot of access to use alternative strategies, also in young children who want to cooperate with the scan but just don't have it together to hold it still. I'd like to acknowledge the different contributors who've helped with this work. Thank you.
Thank you, Simon. It's a little late. What I'd like to do is just thank Simon, and then people can get up and go if they need to go, and then he'll be here till, I guess, about 3:30 is his next meeting. So if people have questions, maybe just come up after now and ask questions. So thanks again for a great talk.